Hello, my name is Siddharth and topic is ultrasound guided intercostal nerve block. There are 11 pairs of intercostal nerves, T1 T11, which are anterior divisions of the thoracic spinal nerves. They course through the intercostal spaces accompanied by the intercostal vessels. They provide sensory and motor innervation to the thoracic and abdominal wall and sensory innervation to the parietal pleura and peritoneum. At the posterior axillary line, the intercostal nerves divide in main and collateral branches. The former is found near the inferior border of the upper rib of an intercostal space. Moreover, approximately at the mid-axillary line, the intercostal nerves give off the lateral cutaneous branches which further divide into anterior and posterior cutaneous terminal branches. To ensure complete sensory blockade, it is therefore important to anesthetize the intercostal nerves at or posterior to the posterior axillary line. Anterior to pleura, in between ribs, 3 muscle layers lies, namely external, internal and innermost internal intercostal muscle. The innermost intercostal muscle is a flimsy innermost muscle layer which readily permits local anesthetic diffusion. Deep to the innermost intercostal muscle is a parietal pleura. From the costal angle onwards, the main intercostal nerves and vessels, grouped as a neurovascular bundle, are arranged in the vein, artery and nerve van orientation from superior to inferior. Neurovascular bundles lies posterior to the inferior border of upper rib, and also in between internal and innermost internal intercostal muscles. Relief of chest wall pain secondary to surgery, trauma, cancer and post-herpetic neuralgia. This block is also used in upper abdominal surgery such as gastroscopy and cholecystectomy. Neurolytic block is also used for persistent post-mastectomy and post-thoracotomy pain. Besides coagulopathy and local infection, lack of expertise are important contraindication. C. The dermatome distribution. Local anesthetic solution injected into the subcostal groove spreads both distally and proximally. Thereby, it blocks the ipsilateral sensory and motor fibers of the intercostal nerves. Some of the drugs may enter perivertebral space too. The usual ultrasound setting, a high-frequency linear probe, resolution mode, depth 2, 4 cm with 5 cm needle in-line approach using 3, 5 ml local anesthetics at each intercostal nerve. Place the patient in the sitting, lateral or prone position. Scan the posterior intercostal space laterally, lateral to the costal angle, but posterior to the posterior axillary line, where the neurovascular bundle has not yet divided. Start scanning at the inferior angle of the scapula, which corresponds to approximately the 7th intercostal space, when the hand is hanging down on the side. Note that when scanning the 2nd to 7th intercostal space, the scapula has to be moved laterally, by hanging the arm on the side, or having the arm reached over to the contralateral shoulder, to allow scanning lateral to costal angles. When we place linear probe in between two ribs appears as a hyperachoic, round/oval structure. In between two ribs, pleura appears as a bright, hyperachoic structure with sliding sign. Anterior to pleura, in between ribs, 3 muscle layers lies, namely external, internal and innermost internal intercostal muscle. Neurovascular bundles in form of intercostal vein, artery and nerve lies in between internal and innermost internal intercostal muscles and posterior to the inferior border of upper rib. Needle is targeted from lower rib to upper rib in plane approach, entering through external and internal intercostal muscle. Here, intercostal nerves are usually difficult to identify as they are very close to the rib, thus visibility is impeded by bone shadow. Also, the nerves are progressively smaller when course beyond the costal angles. But intercostal vessels can be identified by Doppler, and that area is targeted by needle with local anesthetics. An out-of-plane approach, with direct access to the intercostal space, as well as an in-plane technique is possible. With either needle approach, it is important to hydrodissect repeatedly during needle advancement in the tissue plane, before reaching the internal intercostal muscle. This will facilitate visualization of the needle tip, and identify the correct tissue layer. The intercostal muscles, intercostal vessels, ribs and pleura are important landmarks that are easily recognized leading to the intercostal nerves. An out-of-plane approach, with direct access to the intercostal space, as well as an in-plane technique is possible. With either needle approach, it is important to hydrodissect repeatedly during needle advancement in the tissue plane, before reaching the internal intercostal muscle. This will facilitate visualization of the needle tip and identify the correct tissue layer. This block is associated with risk of penetration into pleura, peritoneum and abdominal viscera. Absorption of local anesthetic from the intercostal space is rapid, leading to local anesthetic systemic toxicity. Arterial plasma concentration peaks in 5 to 10 minutes, and venous plasma concentration peaks several minutes later. Let's check out some real block. Block number 1. Block number 2. Let's check out some clinical pearls. Intercostal nerves are not mostly possible to visualize by sonography. This block is having highest serum peak level of local anesthetics. Always hydrodissect so that each layer and needle tip is visualized better. Always attach syringe with needle to avoid pneumothorax during block. Blockade of the 2 dermatomes above and the 2 below the level of surgical incision is required. It does not block visceral abdominal pain, for which a celiac plexus block is required. Thank you very much for your kind attention.